All right, well, this is part 2 of our lecture on the urinary system. Last time we talked about the bladder, and that's where urine is stored until it's ready to be emptied through the process of urination. So at the end of the urinary bladder is the urethra. That's the doorway to the outside of the body, and that passageway, the urethra, is controlled by two muscular passageways or doorways, and they're called the internal and external sphincter. We mentioned that the internal sphincter is not under our control. It opens up via smooth muscle when the impulse to urinate is there, when the bladder has reached its volume. And the external sphincter is the one passageway we can't control because it's made up of skeletal muscle, and that we can control when it's convenient to urinate. So the process of urination is called micturition. So micturition is the process in which we relax the muscles of the urethra and allow bladder to flow. So as the bladder fills with urine, there's stretch receptors in the wall of the bladder that are stimulated as the bladder fills with urine. And those are parts of the nervous system, these sensory receptors, that send signals to the spinal cord. And the spinal cord then turns around and responds back to the bladder by causing the urinary bladder to contract. So the smooth muscle of the urinary bladder contracts, and the internal urinary sphincter relaxes, and the urge to urinate is made aware of at the level of the brain. When this reflex kicks in, we become aware of it. And we can decide to keep the external urethral sphincter closed and prevent urination at that time. But this reflex activity going from the wall of the bladder to the spinal cord and back to the bladder, that's a reflex that we can't control, but we can suppress it for a time until the reflex is so busy and constantly activated because the bladder is so full. That's those times when maybe you've been heading off to work or sitting at the computer with an online class like human biology, and you finally realize, that's it, I gotta stop, I need to go to the bathroom. So that's when that reflex, that activity of those neurons going from the bladder to the spinal cord back to the bladder, that activity is constant, and we can't suppress it anymore with the higher brain centers like the cerebral cortex. So this is just a diagram kind of showing those impulses. So as the urine fills the bladder, it causes the bladder wall to stretch, which sends impulses to the spinal cord and then right back out to cause contraction of that bladder. But again, if it's not convenient, then if we look at the brain will send impulses down to keep that external urethral sphincter closed. Again, we can control that external sphincter, so we'll keep that closed and try to inhibit this reflex that's happening between the bladder wall and the spinal cord. And then when it's time and we want to urinate, we can openly relax that external urinary sphincter and allow that urine to flow. So the urethra then is the opening to the outside from the bladder. Women obviously have a shorter urethra than males do, and because of that, women are more prone to urinary tract infections, because if you look at the urethra right here is very close to the anal opening in females, and as a result of that, sometimes the bacteria from the anal opening can enter the urethra, climb up, move up through this urethral opening and infect the bladder. And if that goes undetected and untreated, it can actually go up the ureter and continue to infect the kidney. So urinary tract infections are not something to be taken lightly. They should be treated with antibiotics and resolved, because they can lead to kidney infections. Some women are more prone to bladder infections than others. It could be the anatomy. We know that there are certain behaviors that increase the risk for urinary tract infections, like little girls who wipe from back to front after having a bowel movement. They're dragging that bacteria from the anal opening through up against the urethra and causing urinary tract infections. So it's not uncommon for young girls ages 4 to 8 to even 10 years old, if they're not using proper wiping technique, wiping from front to back, they can end up with urinary tract infections. Also, nursing home residents that are incontinent of urine or stool or have urethral catheters that exit the urethra, they're also at risk for urinary tract infections. So we always like to remove urinary catheters from patients shortly after surgery because the risk of urinary tract infection goes up so quickly. Even though it's more convenient sometimes to keep that catheter in so they don't have to get up and use the toilet, it's not good for infection risk, so we like to remove them as soon as possible. Another common cause of urinary tract infections in women is intercourse. If the male touches the anal opening prior to intercourse and then goes upward too high and touches the urethra, then inserts the penis properly into the vaginal opening, if there's this excess touching of areas that have bacteria, that's going to increase the risk for a urinary tract infection. So it's given the name honeymooner's urethritis, which is urethritis is another word for inflammation of the urethra, and honeymooners meaning that young couples that are engaging in intercourse and not inserting the penis exactly where it needs to go can sometimes drag bacteria up into the urethra. A common way to prevent urinary tract infections related to intercourse is for the female to urinate after intercourse, because that natural flushing mechanism will kind of keep this area washed out and cleaned through the action of acidic urine passing through there. That'll keep the bacteria out of that urethra. So sometimes the prostate in men, it encircles the urethra just below the bladder. So the prostate gland is located right here, and it encircles the urethra. If that gets enlarged, it makes this passageway very narrow, and it makes it difficult for older men to urinate. So men over the age of 70 have some enlargement of the prostate, some more than others, and it can cause difficulty with urination. And the more they strain and bear down to urinate, the more that will constrict that opening. So it's a real challenge for older men sometimes to completely empty the bladder. So when we look at the reproductive system in males and females are a little different in terms of how it hooks up with the urinary system. For example, in males, the urethra is the passageway for both semen and urine. But in females, the tract for the reproductive system is the vaginal canal for menstrual flow or birth of baby only, and the urinary system is a completely separate, tube system. So the urethra and the bladder, especially the urethra, are not related to the reproductive system at all. It's a separate opening. So when we look at the kidney then, we're going to kind of zero in on the major organ of the urinary system, and that's the kidney. The outer layer we call the cortex, the inner layer is the medulla, and the pelvis is the space where urine is collected in the kidney before it enters the ureter. So if we look at this diagram here of the kidney, the lighter portion is called the cortex. That's where urine formation begins. You can see the renal artery brings blood in and it branches out to the cortex, and then there's special structures that will receive the filtered contents of that blood that is filtered out in the cortex, and then urine is made and it drains into the pelvis. So the pelvis is this region here, this kind of central region at the, here's the ureter. The ureter opens up into the pelvis. So urine is collected here from the kidney, starting from the outside at the cortex, and then it travels down the ureter. So the pelvis is this kind of beige, large area here where urine is collected before it moves down the ureter. And the medulla are these darkened triangular regions, which we call renal pyramids. This is the medulla, the darkened region. So the structure, the functional and structural unit of the kidneys are what we call nephrons. Nephrons are what actively filter the blood, and they receive the plasma that is filtered from the blood vessels into the kidney for urine formation. So it's the nephrons that are doing the work of the kidney. So again, we have the cortex on the outside, the medulla are these triangular darkened regions toward the middle of the kidney, and then here's the pelvis where urine formation collects from each portion of the kidney, and then it enters the ureter. So looking at the nephron, there's some special structures you need to be aware of, and it's best to look at a diagram to kind of see that. So I'm going to move down here. You can look at this diagram. So when we look at the blood vessels as they enter the kidney, Here's the medulla, those darkened pyramids, and here's the cortex, the outer edge. That's where urine formation starts. So the blood that is carried in from the urinal artery, it branches into several different blood vessels before it finally enters what we call the small vessel here, the afferent arteriole. That leads to a little tuft of capillaries, which we call the glomerulus. So that's what this is. This round tuft of capillaries is the glomerulus. Here's a real picture of a glomerulus taken with a photomicrograph. And here's another one, all these glomeruli and the blood vessels that lead to and from the glomerulus. So it's a tuft of capillaries. It's actually a blood vessel. So the blood enters into that. But this blood vessel, or this capillary, is leaky, and the fluid can leak out, but the red blood cells, the white blood cells, proteins, large proteins, and platelets, that remains in the glomerulus, and that leaves via the efferent arteriole. So the afferent arteriole leads into the glomerulus, the efferent arteriole leads away from the glomerulus, and this tuft of capillary is the glomerulus. So the fluid that's squeezed out enters into this cup-like structure that wraps around the glomerulus. This is called Bowman's capsule. So this rounded beige structure that receives the squeezed out plasma from the glomerulus is called Bowman's capsule. And then it enters this tube, which is called the proximal convoluted tubule. And it's just this upper portion here that's called the proximal convoluted tubule, because once it dips down into the medulla, it changes its name. This U-shaped structure here is called the loop of Henle. So the loop of Henle is down into the medulla, and then it comes up again and forms the distal convoluted tubule. So this is the distal convoluted tubule up here after the loop of Henle, and before it is the proximal convoluted tubule. And wrapped around these distal and proximal convoluted tubules is an extension of this efferent arteriole. These are called the peritubular capillaries. So there's an exchange going on throughout this process. Even though some urine, some plasma enters into these tubules, there's still exchange between the blood and these tubules that's occurring throughout this process. So proximal distal convoluted tubule out in the cortex with the peritubular capillaries wrapped around it. And then when that is complete and that plasma that was filtered out here, squeezed out at the glomerulus, when that plasma becomes urine, it enters into the collecting duct. So the collecting duct has more than one distal convoluted tubule connecting to it, and that will all drain toward that pelvis of the kidney. So we see the bottom of the collecting duct and the loop of Henle in the medulla portion of the kidney, in that dark triangular portion I showed you in the earlier diagram. So it's important to understand this whole tubular network here, the beige tubule, starting with Bowman's capsule and ending with the distal convoluted tubule. This is all called the nephron. And then the blood vessels that wrap around it are part of the cardiovascular system. Again, these blood vessels up here are called the peritubular capillaries. And this special blood vessel network down here, this is called the vasa recta. But it depends on where or how long this loop of Henle is. So for our purposes, we're just going to call all these blood vessels, whether they're red, purple, or blue, we're going to call those the peritubular capillaries. So there's three processes that occur in this nephron, and they're called glomerular filtration, tubular reabsorption, and tubular secretion. So the first process that happens as blood enters into that afferent arteriole and glomerulus is called glomerular filtration. So glomerular filtration occurs here at the glomerulus when the fluid from the blood is squeezed out of this leaky glomerulus into Bowman's capsule. We call that process glomerular filtration. So let's take a look at this diagram that really summarizes all those steps. So glomerular filtration is happening here. It's a movement of fluid out of the glomerulus into Bowman's capsule. So things like water, salts, nutrients, water, waste molecules, all that is squeezed out into the glomerulus. And this is a nice little diagram up here showing you everything that leaves the glomerulus and enters into Bowman's capsule. But some of these things we need back. Our water, glucose, amino acids, we need those back in the blood. So we don't want to just lose that to the nephron and have that enter the bladder, because we would lose our entire blood volume in about 30 minutes if we didn't get some of this stuff back. And that's the job of tubular reabsorption. Reabsorption, most of that occurs here in the proximal convoluted tubule. So as that fluid enters into this proximal convoluted tubule, there's cells that actively reabsorb glucose, water, salt, and amino acids and take it right back to the blood, right back to these peritubular capillaries, which we can see go right back to the renal vein and back to the circulation. So we don't want to lose water, a lot of water, glucose, amino acids, and salt. So tubular reabsorption is going to send it right back to the blood so it doesn't enter the urine. And then the third process, tubular secretion, is when sometimes we have excesses in the blood. That's going to be secreted from the blood into the nephron. So excesses of salt, like if you had a lot of salt for lunch or dinner, for example, those excesses are going to enter the blood from the nephron. So as it enters a nephron by tubular reabsorption, glomerular filtration, tubular reabsorption is going to take things back to the blood, but tubular secretion is going to take it from the blood to the nephron to enter the urine. So there's some things we don't want to stay in the blood, and some of those waste products are excesses of water, urea, uric acid from eating proteins, salts, ammonium ion, and creatinine, which is used, which is a byproduct of muscle metabolism. So those are wastes in the blood that need to either not be reabsorbed, or in some cases they're actively secreted. So another example would be like hydrogen ion. If we have a high acidity in the blood, the kidneys will secrete hydrogen ion from the blood and put it into the nephron to get rid of it. So think of tubular reabsorption as reclaiming things that were filtered out of the blood at the glomerulus, so we were taking it back to the blood, and tubular secretion is removing it from the blood and putting it into the nephron. So we want to get rid of excesses through tubular secretion, and we want to save nutrients through tubular reabsorption. So when we look at, the reabsorption, the things that we take back from the nephron to the blood, 99% of the water that's filtered out of the glomerulus into Bowman's capsule is taken right back to the blood. So very little of that water that is filtered out of the glomerulus entering Bowman's capsule actually enters the urine. 99.5% of our sodium, again, we need it in our blood, we'll take it right back. Glucose, 100%. Never should we see glucose in the urine unless a person is diabetic or is under a great deal of stress. Glucose is something that our body always stores, never wants to get rid of, and that's why we have such an obesity issue, because the body doesn't get rid of excess glucose, it stores it as fat. And then urea, we can see that's actively, left in the kidney. We only reabsorb about 44%. The rest is going to be excreted and remain in the nephron to be urinated away. So that's a waste product. But these first three, those are really important. Another one that's not shown here are amino acids. Amino acids are also completely reabsorbed. So glucose and amino acids, 100% reabsorbed. We should not see those in the urine. But what happens when it does enter the urine, again, that's a sign of diabetes. Diabetes is when there's a lack of insulin released from the pancreas, and as a result, there's too much glucose in the blood, and there's no insulin to allow it to enter the cells, so it builds up in the blood, and the kidneys simply can't transport all that glucose back to the blood after it's filtered out of the glomerulus, so the glucose remains in the blood and enters and spills into the urine. We'll talk more about diabetes and how that occurs and symptoms of it when we get to the endocrine system. So urinalysis is a nice way of looking in a non-invasive way at the function of the kidneys. So sometimes people go to the doctor, they want to do a urine sample, and they'll look to make sure that the urine is a pale yellow. And the more pale it is, the more well hydrated a person is. But urine should never be completely clear. That's a sign of overhydration. And it should never be dark yellow, which means there's not enough fluid in the body and they're maybe dehydrated. But we should not see glucose or ketones. Ketones are a byproduct of excess protein and fat metabolism. We don't want to find excesses of that. Nitrates and nitrites, that can be a sign of a urinary tract infection. We shouldn't see blood. We shouldn't see red or white blood cells because that glomerulus is only leaky to fluid, and anything dissolved in the fluid, which is our plasma. Remember, plasma is the fluid part of our blood. So we shouldn't see the solid parts of blood. We shouldn't see red or white blood cells or, large proteins. Those should not be able to squeeze out of the glomerulus because of their size. So if they have squeezed out, then that's a sign that there's damage to the glomerulus, and that's kidney disease. Sometimes we can have bleeding that occurs in white blood cells with a urinary tract infection. So it's not a problem with the kidneys, but it's a problem with the tract. There's bleeding in the bladder, inflammation in the bladder or the urethra. So there's a number of different reasons. And blood can appear in the urine just because a female is, having her menstrual period. So that's not coming from the kidneys or the bladder at all. It's just entering the urine as the vagina is leaking a little bit of blood with menstruation. So anyway, when we look at the kidneys, we want to look and see how much of these waste products are building up in the blood. So urea is produced by the liver during protein metabolism. Uric acid, again, part of protein metabolism. All body cells make uric acid, and the muscle cells release creatinine during metabolism. We'll talk about that when we get to the muscular system. But those are all wastes in the blood that when they build up can be dangerous and cause death. So the kidneys will excrete those. It will not reabsorb those as they enter into the nephron, and we can get rid of those. We also see some of these products in our sweat. So sweat is water, salt, and urea. So we expect to see that in the sweat and the urine because it's a sign of the body trying to get rid of those waste products. But if there's too much urea in the blood, people get a white coating on the skin. It's called uremic frost. It's because the kidneys aren't able to secrete urea, so there's so much urea in the blood as it enters the sweat, it's extra concentrated in the sweat and causes that white appearance on the surface of the skin. So the urinary system, again, is just working to maintain fluid levels. So when we talk about medicines like diuretics are medicines we give people with high blood pressure to increase the kidneys' formation of urine. Because when people have high blood pressure, sometimes they have too much fluid, too much salt in the blood vessels, causing that high blood pressure. So when we give them a medicine called a diuretic or a water pill, some of those are called Lasix or furosemide or hydrochlorothiazide. There's a bunch of different ones on the market, but essentially their job is to turn on that kidney and get it to decrease the reabsorption of water. Therefore, more water stays in the nephron and enters the bladder and leaves the body. And that's going to decrease the blood volume and the blood pressure. So those are really important medicines for people with high blood pressure. Caffeine is another medicine that decreases the reabsorption of sodium, which causes decreased reabsorption of water, which again causes more urination, less water remaining in the bloodstream. So that is can sometimes not be good for people that are a little dehydrated and they only rely on their morning coffee as their fluid intake. So it's important if you're a coffee drinker that you also drink water, because caffeine is a natural diuretic causing people to lose fluid through urination. So when you look at the kidneys for acid-base balance, it's important for the kidneys to reabsorb bicarbonate ion to raise our blood pH and to secrete hydrogen ion to lower blood pH. So the condition of any time our blood pH falls below 7.35, which means our pH is too low, we call that acidosis. Because our normal blood pH should be 7.35 to 7.45. So if it falls less than that value of 7.35 out of the normal range, again, acidosis. Above that, alkalosis. So the alk prefix means it's too basic. So in that case, the kidneys will not secrete as much hydrogen ion and not reabsorb bicarbonate ion, because bicarbonate ion, again, remember, it causes things to go basic. So if we need to lower the pH, we're going to hang on to hydrogen ion decrease the secretion of that. If we have to raise the pH, then we're going to secrete excess hydrogen ion and reabsorb bicarbonate ion. So those are really the two major ions that the kidneys can control is, again, the hydrogen ion and bicarbonate ion. So here's the nephron. So we can see that bicarbonate ion can be reabsorbed back to the blood if our pH is too low, and we can secrete hydrogen ion into the nephron. So this is tubular secretion because it's going from the blood to the nephron. So we can secrete excess hydrogen ion into the kidneys if the blood pH is too low. So these are two things that'll happen to correct a low pH. We would reabsorb bicarbonate ion and we would secrete hydrogen ion. Both of those actions together are going to help to raise a low pH. So we already talked about some of those disorders. Urethritis is just infection of the urethra. Cystitis, infection of the bladder. You can have both of those at the same time with a UTI or urinary tract infection. And again, if that goes unchecked, a person can end up with infection of the kidney, which is called pyelonephritis. So the rest of these are just disorders of the kidney. I typically let you work on these, look at these on your own. And your topic for the discussion board this week is looking at hemodialysis. So I look forward to seeing your comments on that in the discussion board.